Dear students, today's class is on interdisciplinary periodontics and recent advances in periodontics. We'll go on to the learning outcomes. The learning outcomes for today's topic is describe the role of periodontist in various interdisciplinary procedures, explain the effectiveness of periodontal therapy during interdisciplinary procedures like orthodontics, restorative, prosthodontics, endodontics, and the possible interrelation and treatment possibilities. Coming on to the introduction, what is the importance of interdisciplinary dentistry and periodontics? The role of periodontics in interdisciplinary dentistry. The role of periodontics is to achieve a long-term therapeutic target of comfort and ease of restoration and maintenance care, good functional treatment predictability and longevity of the treatment. The rationale of interdisciplinary dentistry is to achieve a long-term therapeutic target of comfortable, good functional treatment predictability, longevity and ease of restorative and maintenance care. Active periodontal infection must be treated and controlled before the initiation of restorative, aesthetic and implant dentistry. So the periodontal health is the sine qua non, a prerequisite for successful comprehensive dentistry. So whatever interdisciplinary dentistry, the periodontal health is more important when it comes to interdisciplinary dentistry. So what are all the things we are going to see in the role of periodontist in interdisciplinary dentist? How periodontal therapy going to help in interdisciplinary dentist, or what are all the treatment should be done or can be done in interdisciplinary level when it comes to periodontics. So we'll see about restorative, endodontic, orthodontic and prosthodontics. When it comes to restorative dentistry, the main important thing is a biological width. The biological width consideration, aesthetics, occlusal consideration and special restorative considerations. The biological width, the margin placement and the biological width is more important when placing a crown or a filling. If the placement of the crown or the filling violate the biological width, then there will be disease. So the periodontist role is to make sure the biological width is not violated. That is what the relation between resto and perio. So what is biological width? Biological width is the combined width of connective tissue and epithelial attachment superior to the bone, which is the dimension of the space that the healthy tissue, gingival tissue, occupies above the alveolar bone, which is coronal to the alveolar bone, which usually will be 3 millimeters, 1 millimeters of sulcus depth with 2 millimeters of biological width, which is a combination of junctional epithelium and connective tissue attachment. So biological width violation can be corrected either by surgical means or by orthodontic or a forced extrusion of the tooth, such that the tooth moves away from the bone margin. So the width of 2 millimeter is maintained. That is the idea of biological width maintenance. If the biological width is violated, if it is less than 2 millimeter, the gap between the margin of the crown and the crust of the alveolar bone, then there will be disease process happens. Once there is a disease process, there will be periodontal gingival recession or there will be bone resorption happens because of the violation of the biological width. So the periodontist role is to prevent the violation of biological width, or if it is violated, the role of the periodontist is to correct the biological width violation. So this is an example or a margin placement guidelines where the margin should be placed when the patient is treated with either a crown or with a subgingival fillings. So if the probing depth is 1.5 millimeters or less, place the restorative margin 0.5 millimeter below the gingival tissue crest so that it will not violate the biological width. If the probing depth is more than 1.5 millimeter, you can keep up to the of the depth of the sulcus. If it is more than 2 millimeter, you can think about doing a gingivectomy and bring back to 1.5 millimeter sulcus depth and keep the gingival the restorative margins 0.5 millimeter below the gingival tissue. Why we are worried about the margin placement? If there is more deeper probing depth and the margin is placed, there will be lot of food accumulation happens. If the biological width is violated and the space between the margin and the bone is very less, then again there will be inflammation and either gingival recession or bone resorption, which results in exposure of the gingival margin, that which we don't want. The main idea of placing a margin placement guidelines is to make sure the patient can able to maintain the gingiva in healthy state. The next problem, interdisciplinary problem we usually encounter is occlusion. For a restorative dentist wanting a high degree of predictability, in the final restoration, the occlusion should be understandable. You should understand the value of occlusion before placing any restoration. If there is a minimum eye points in the occlusion also, it will result in periodontal destructions and angular bone loss, or it may result in mobility. A mild amount of high point on a restoration may lead to periodontal breakdown. So occlusion is a major role in periodontal disease also. So when it comes to occlusion, you have to evaluate your restoration. It should not be any high points, and the periodontist role is to make sure the occlusion is in proper way so that it doesn't impair the periodontal health. Next interdisciplinary is endodontics. Perio-endo management, the classification stated that either it will be a primary perio or primary endo, or combination of primary perio and primary endo with secondary perio or endo, or combination of both. Okay, so endodontic lesions can lead to periodontitis, or periodontal lesions can lead to endodontitis. Both is possible. So the treatment should be followed based on the type of lesion. If it is a primary endodontic lesion, just by treatment of endodontic lesion alone will resolve the secondary periodontal lesion produced by the primary endodontic lesion. If it is a primary periodontal lesion which resulted in endodontic sequelae, then you have to treat endodontic lesion as well as periodontal lesion. Both has to be treated to get back to the healthy state. The next possible interdisciplinary relation is orthodontics. Orthodontic patients always perio plays a major role in orthodontic, whether it is a pre-orthodontic periodontal treatment or post-orthodontic maintenance, or maintenance of oral hygiene during the orthodontic procedures. All the way from the beginning of the procedure until the end of the orthodontic treatment, the patient should be monitored by a periodontist for its oral hygiene. Next interdisciplinary relation is prosthodontic. When it comes to prosthodontics, either it may be a pre-prosthetic surgery or a procedure which requires RPD or a provisional denture which distributes the occlusion load. We have to decide what is the pericemental area of the periodontium, whether the periodontium is able to support the denture or removable denture or a fixed partial denture, whatever it is. So the periodontist role is to evaluate the status of the periodontium when it comes to prosthodontic management, whether the patient requires any bone augmentation for ridge replacement, or either soft tissue augmentation for ridge defects, or it may be a periodontal evaluation for a prosthetic replacement of a missing tooth. So the adjacent tooth has to be evaluated for periodontal status before you go for a removable or a fixed partial denture. This is the interrelation between restorative, endodontics, orthodontics and prosthodontic department. So basically the resto departments all have an interrelation between each other. The second part of the class is recent advances in periodontics. When it comes to recent advances, we will think about what are all the we are going to talk about what are all the recent advances in material aspect, instrument aspect, procedural aspects, and what are all the future concepts. We'll start with material aspects. So materials used for regenerative therapy, the newer materials whatever have been introduced are root biomodifying agents or guided tissue regeneration, bone graft materials, growth factors, and soft tissue grafts. We'll see one by one what are all the newer materials available in each of this category. So we'll start with root biomodification. So root biomodification, we can use an EDTA, 24% EDTA root surface conditioning agent, which is topically applied onto the exposed to root surface during periodontal surgery. The example or commercially available product is a Prof gel. This is basically an material which is going to remove the smear layer from the root surface and enhance the formation of or regeneration of the cells in the diseased root surface. So basically you have to remove the plaque and calculus, debride the surface, then apply the gel, the Prof gel onto the exposed root surface, rinse it thoroughly with saline, and then if you require a graft material like bone graft, you can place a bone graft and close, or you can just close the site without any bone graft. That depends on the site, whether it is 1 wall defect or a 2 wall defect or a 3 wall defect. There are studies shown that there will be a better regeneration after the use of this material. This is one of the advanced materials available, commercially available, which can be used for periodontal regeneration. The next material is emdogain. Emdogain is nothing but an amelogenin, which is an enamel matrix protein which is seen in enamel or cementum. Basically the idea of using this material is to regenerate cementum. So when it comes to regeneration, we have to regenerate periodontal ligament, cementum, alveolar bone, and gingiva, connective tissue. So all four has to be regenerated, then only it is called as regeneration. If any one of these is not regenerated, and then it is only called as repair and not as regeneration. So we have to replace cementum, the lost cementum in the place where it is lost. We have to replace the periodontal ligament, and we have to replace the bone and connective tissue. All this has to be replaced in the place where it has been lost. That is the role of regeneration. The main idea of using emdogain is to regenerate cementum. The biggest problem in regeneration is regenerating a new cementum. So they try to use amelogenin so that it is an enamel matrix protein. It has the capability of producing cementum. But what is the drawback of using this protein is this can produce a cellular cementum, but it cannot be able to produce an acellular cementum. But the bad thing is, or the worst part is, the coronal portion of the root surface is covered by acellular cementum. Once there is a disease, this acellular cementum is necrosed and removed. Once you remove the acellular cementum, it is very difficult to regenerate acellular cementum. Whatever studies have proven that we can regenerate cementum only a cellular cementum. We need cells to regenerate the cementum. So whenever there is a cell in a cementum, it is called as cellular cementum. So we need to produce a acellular cementum. The cementum should not contain any cells, which is very difficult till date. We cannot able to achieve a acellular cementum formation in the coronal part or in the cervical part of the root surface in the regeneration, but we can able to produce a cellular cementum with the help of this emdogain. So this is a case picture of use of emdogain on a intrabony defect. Next material is bone ceramics. Bone ceramic is a fully synthetic bone substitute material. So it is basically a tricalcium phosphate 40% with 60% of hydroxyapatite. The resorption character for this material is almost equal to the bone replacement time, so that this material can resorb and replace it by the bone. This is a material basically a bone substitute, which is an osteoconductive material. So it is going to be stay there and it will be replaced by bone over the period of time. The another material is GEM21S, which is a growth factor enhanced material, which is combined with this beta tricalcium phosphate so that it can induce bone formation. The previous material what we have seen is a osteoconductive material. This is more towards an osteoinductive material. Osteoinductive material, which is a combination of a bioactive protein, which is a human platelet derived growth factor, along with beta tricalcium phosphate, and it has been proven to some extent that the bone induction and bone formation occurs after the placement of this graft material. So PDGF is a broad acting growth factor with mitogenic and chemotactic effect on osteoblast, cementoblast and periodontal ligament cells. So this can induce formation of bone, cementum and periodontal ligament. Basically it helps in regeneration of the tissue which is lost in the space. So the PDGF released from the beta tricalcium matrix into the surrounding environment bind with a specific cell surface receptors on the target cells, initiate the intracellular signaling pathway. By initiating the intracellular pathway, it induces the formation of the required cells on the site. So it induces intracellular events led to directed cell migration and chemotaxis and cell proliferation, mitogenesis of osteoblast, periodontal ligament fibroblast and cementoblast. So this is a clinical case of use of this material. So you can see the radiograph, the preoperative and postoperative. There is some amount of bone fill happens over a period of time. The next material is PEPGen 15. PEPGen 15 is the first and only bone replacement material that combines the organic and inorganic components of the allogenous bone and perfectly mimic the cell binding sequence of type 1 collagen. So basically this is a material which mimicking the normal regular bone. So the cell binding PEPGen P15 accelerate the bone binding of the cells to the particle matrix and initiate the cascade of event that results in the formation of new bone. So the formation of new bone has been proven to cause differentiation of variety of different fibroblasts to bone forming cells. It supports the physiological process that result in the formation of new bone. So the PEPGen 15 accelerate bone regeneration and within the healing process. So next material is allodem. It is basically a soft tissue replacement graft material. So allodem is an acellular dermal matrix derived from a donated human skin that undergoes a multiple steps process which removes both the epidermis and the cells that can lead to cell rejection. Basically this is a regenerative tissue matrix which is a acellular dermal matrix, a dermal matrix with removed all the cells, only the collagen matrix have been made and which has been packed. So the regenerative tissue matrix allodem provides a matrix consists of collagen, elastin, vascular channels and protein that support revascularization, cell repopulation and tissue remodeling. So basically this is a material for soft tissue coverage or regenerative procedure for gingival recession. You can use this material to regenerate soft tissue. It is a very good material. You can see a clinical photograph of use of this allodum in a class 1 gingival recession case. So the post-operative, you can appreciate the difference between the pre-operative and post-operative picture. Next is soft tissue ridge augmentation. Soft tissue ridge augmentation, again you can use the allodum. The next part is growth factor or bone morphogenic proteins. These bone morphogenic proteins are now produced using recombinant DNA technology. The BMP2 and BMP7 have been shown in clinical studies to be beneficiary in the treatment of variety of bone related procedures. Basically it is a bone morphogenic protein which is one of the protein which is responsible for bone regeneration, osteoblast activity. Once this protein is the one which is going to initiate the polymorphonuclear neutrophils or the macrophages into modified into a osteoblast. Basically the pluripotent cell into a mesenchymal cell and a mesenchymal cell into a osteoblast. We need a osteoblast to induce bone formation. Basically this is on the line of bone formation. This protein is one of the protein which is going to change the pluripotent cells or the mesenchymal cells into osteoblastic cells. So these materials are commercially available as a growth factors in bone regeneration. Next material available is recombinant platelet derived growth factor. Platelet derived growth factor is again one more important protein which is responsible for regeneration. So these proteins have the ability to regenerate the cells which is required for regeneration. It can induce the cells which is required for regeneration. For example, induction of fibroblast, induction of osteoblast or formation of osteoblast and cementoblast can be done with this protein. Basically after this protein only the bone morphogenic protein will come. Then next after the bone morphogenic protein comes into the site, then the osteoblast formation will happen. So basically after the wound, there is a wound, the wound will be replaced by platelet derived growth factor where the platelets comes to the site, it repopulate the site and release this growth factor which changes the cells into a mesenchymal cells. Once the mesenchymal cells inside the defect site, then it requires a bone morphogenic protein for its action to convert into an osteoblast. So we need different proteins at different stages of healing for regenerative procedures. So all this protein present at the same time will not induce regeneration. So each and every protein requires at a specific time duration. So for example, if it is in the first week, the site should have platelet derived growth factor. In the second week it requires a bone morphogenic proteins, and then only it will convert it into osteoblast and then it forms a bone. So we need different proteins at different time interval to induce bone formation. That is the very difficult part in periodontal regeneration. We can give all the growth factor at the same time, but all the growth factor will not stay at the place for longer duration. So we require only a specific growth factor at a specific time to induce regeneration. If a non-specific growth factor which is a bone morphogenic which is present in the first week will not induce bone formation, or a platelet derived growth factor which is present in the second week will not induce bone formation. That is the problem with periodontal regeneration. So these growth factors are commercially available as a regenerative material, but the predictability of these growth factors in the site depends on the individual. So it should be spatially present at the required time and at required amount. Both should be important for regeneration to happen. So we'll go on to the material aspects, instrument aspects. We have seen the material aspects. We'll go on to the recent advances in instruments. What are all the recent advancements in instruments? The recent instruments are perioscan, vectors, lasers, membrane autotags, piezoelectric surgeries, microscopic surgeries, and destruction osteogenesis kit. Perioscan, what is the advantage of this newer instrument? Is basically it is a scaling instrument, but the advancement is it has a ring at the tip of the instrument which will tell you whether there is a calculus present or not. So when it touches the calculus surface, it will give a blue color. Once the calculus is removed from the surface and it touches the healthy root surface, it will turn into green. So you will know whether you are removing calculus, cementum, or root surface. By that you can minimally do an invasive procedure very minimally. That means you can do a root debridement without removing healthy cementum. You will remove only calculus. Wherever there is calculus, it will give you a blue light. Once you remove the calculus, it will turn into green. So you can able to identify whether there is calculus present or not without any tactile sensation. That is the advantage of this material instrument. But the problem is it is too costlier to afford. The next instrument is vectors. Vectors, again, it is an advanced instruments for scaling. A vector converts the ultrasonic dynamics of 25,000 Hz in such a way that you as a dentist can work in a completely relaxed and non-traumatic manner, quickly and efficiently. The instrument tips does not generate heat and does not therefore requires water coolant. Vector destroys bacterial biofilm, endotoxins, and removes plaque and calculus, leaving a smooth root surface. The advantage of this instrument, it removes the biofilm, plaque, calculus, and endotoxins from the root surface without damaging the root surface. That is the advantage of this vector system. The next advancements is laser. The hard tissue lasers have been introduced which can be used to do scaling. So the erbium lasers groups have emerged as a promising laser system for periodontal therapy. So these can be used for detecting and removal of calculus in a better way. The next instrument is membrane autotag kit. So the difficult part in periodontal regeneration is containment of the graft. Once we place the graft material in the site, if it is a two-wall defect, the graft material will come out. So we have to keep a membrane. The problem with the membrane is the membrane should stay in the place for the period of the next 3 months or 6 months time, so that the regeneration happens without any hassle. Most of the time the problem with what happens is this membrane will not stay in position for a longer time. Either it imbibe with the plasma fluids in the sulcus and it gets come out of the soft tissue, or it dislodges from the site, which results in failure of regeneration. This is an instrument which is introduced to make sure the membrane is tagged onto the bone so that it stays in the place for the time period of regeneration. That is the advantage of this autotag kit. So it will make sure the membrane is placed in position for the time period of regeneration. Next advanced instrument is piezoelectric surgery. If you would have seen implant dentistry, you must have seen a physio dispenser and an instrument with a piezoelectric surgical instrument or a drilling instrument you must have seen. So these piezoelectric surgical instruments are the advancements which result in minimal injury to the soft tissue and maximize the surgical precision and intraoperative sensitivity. So you can give a precise cut of bone or the soft tissue with the help of these piezoelectric surgical instruments. So the high frequency oscillation between 24,000 to 29,000 Hz modulated with a low frequency between 10 to 60 Hz enable efficient and controlled use and improve the healing of the tissue. So this is one of the advancements in surgical aspects. So with this help of this instrument you can cut the bone very precisely. Next advancement is microsurgeries. Periodontal microscopes can be used for microsurgeries. So the microsurgeries will help you in periodontal plastic and aesthetic surgery. See, if you are planning to do a in papillary reconstruction procedure, it is very difficult to do with a normal vision. You cannot achieve an 100% success rate of plastic surgery in papillary reconstruction or gingival root recession coverage procedures. This is one of the advancements where you can use microscopes to do a periodontal surgery. So the ability to perform the surgery with greater precision, making more precise incision, and the ability to use smaller instruments that cause less trauma and faster post-operative healing. The precise tissue restructuring with smaller needles and stitches, so very useful for soft tissue augmentation procedures, mainly the perioplastic procedures. A better view of radicular root surface and leading to a easier radicular root instrumentation, in turns leading to more effective removal of local factors and correcting of bone defects can be done with the help of these microscopic surgeries. The next part is destruction osteogenesis. You must have heard this in orthodontics, this destruction osteogenesis. You can use destruction osteogenesis in perio also for ridge augmentation. You can distract the bone coronally. So in destruction osteogenesis in ortho, you should have seen the bone has been moved mesiodistally. Here we can move the bone apicocoronally. So vertical ridge augmentation can be achieved with the help of this destruction osteogenesis. So coming on to the future trends, what are all the future trends? The future can be recombinant growth factors and biomimicking agents, gene therapies, stem cell therapy and tissue engineering, nanotechnologies. So we will see one by one. Gene therapy. It uses purified preparations of a gene or fractions of the genes to treat a disease. In periodontics, use of platelet derived growth factor gene delivers and bone morphogenic protein delivery, which can help in production of regeneration. So genetic approach to biofilm, antibiotic resistance or genetic therapy, periodontal vaccinations are some future trends, but it's in primitive stage. Periodontal vaccination is really in primitive stage. We cannot able to eradicate all the bacteria through vaccine. The next is stem cell therapy and tissue engineering. The science of tissue engineering aims at the repair and of the damaged tissue as well as the creating a replacement of the lost one. So use of mesenchymal stem cells naturally residing within the bone marrow for true regeneration purpose. So the use of mesenchymal stem cells for regeneration have been tried. It is still under study. So we don't have an material directly available for the clinical use. Still it is in primitive studies. You can use mesenchymal stem cells, but the problem is again we need proteins for these mesenchymal stem cells to convert it into the required cell what we want for that site. For example, if you want to grow bone, you need platelet derived growth factor, you need bone morphogenic protein at different time interval along with this mesenchymal stem cell to convert into an osteoblast. So for this MSC to convert into an osteoblast, you need proteins. Those proteins should be available at the required time. That is the difficult part in getting this study done. Next is tissue engineering procedures, either passive or active tissue engineerings. Passive tissue engineerings, where therapies based on guided tissue replacement, barrier membranes, biologically based acellular dermal matrix, all these are already available, and future enhancements they are trying with this passive engineerings. And active engineerings like enamel matrix derivatives, amlogen, the endogain, the growth factors, beta tricalcium phosphate with platelet derived growth factors, collagens, all these have been tried and under research. The final part is nanotechnology, uses of nanomaterials. So nanomaterials are those materials with components less than 100 nanometers in at least one dimension, including clusters of atom grains less than 100 nanometers in size, or fibers that are less than 100 nanometers in diameter, films less than 100 nanometers in thickness, or nanoholes, and composites that are a combination of these. So nanomaterials for periodontal drug delivery, example triclosan nanospores or chlorhexidine nanoparticles are been in trials. So nanomaterials for periodontal tissue engineering is still under study. These materials can help in periodontal regeneration and periodontal maintenance. So to conclude, repair of periodontal tissue destruction caused by periodontitis is a major goal for regenerative therapy. There will be limited success achieved by utilizing various general approaches such as use of bone substitutes, bone grafting procedures, and cell occlusive barrier membranes. Many research are being conducted in cooperation with various technologies, materials, and procedures to achieve a true complete regeneration of lost periodontal structures. The basic aim of periodontal regeneration is to regenerate all the structures which has been lost due to disease. Either it is a periodontal ligament, bone, cementum, or a connective tissue. All has to be replaced. Then only it is called as regeneration. So the research or keep going on based on this aspect. So in future we can able to see some new technologies which can achieve this periodontal regeneration. That is the role of these recent advancements and future trends. Thank you.